Hello, everybody. So I presented this topic at the Dermacon International meeting recently in Mumbai, and I thought for those of you who haven't had the opportunity to attend the meeting, I thought I'll record the session, record the presentation so that you can understand how I approach subepidermal blistering diseases. Well, the first question that we need to ask is, given that most acquired autoimmune subepidermal bullous disorders respond to similar immunosuppressive treatment, why is it important that we differentiate them into various subtypes? Okay, and the subtypes are confusing, and we take a lot of time to differentiate them. How important really is it to solve the conundrum? Well, does it have any prognostic implications, whether we call it anti-laminin 332 type of mucous membrane pemphigoid or whether we call it P200 pemphigoid? Well, the treatment is the same, I have to say. Most of them respond to usual immunosuppressants, steroids or methotrexate, or if you want to give them cyclosporin or rituximab, they do respond. But there are some blistering diseases like these two that have an increased risk of solid cancers. That's probably a minor thing, actually. Are there any disease-specific treatments that may change? Well, unless it's dermatitis herpetiformis, when you want to advocate gluten avoidance, most other diseases respond to similar treatments. Well, first of all, I'd like to pop in a question, and this question is relevant because I'll explain in the next few slides. Now, which of the following is not a differential diagnosis? What you're seeing here in this section is a papillary dermal microabscess. You're seeing lots of neutrophils, and in the papillary dermis, it's a subepidermal blister with neutrophils. So when you're seeing subepidermal blister with neutrophils, you're thinking about either dermatitis herpetiformis, linear IgA, Bullous LE, or the inflammatory variant of EBA, epidermolysis bullosa acquisita. Bullous pemphigoid usually has eosinophils, and therefore, if this is a question posed to you, the answer is bullous pemphigoid. Now, why is this important? I'll explain. So, there you go, subepidermal microabscesses. These are differentials, and bullous pemphigoid is not the answer. There are three major clues to solving the conundrum that I would advocate. The first and foremost is a detailed clinical history. Without the history, you cannot really report a blistering disorder just on H&E alone. The next, apart from the history, is the clinical appearance, the picture. All right. And the third is a correlation between the history, clinical picture, and the histology. Histology does indeed play a minor part, in my opinion. And histology is important. It is important, fair enough, but it does play a minor part for the patient, and I'll explain why. So first you determine the type of cell, whether it's cell poor or cell rich, and if it's cell rich, then you determine whether they're neutrophils, eosinophils, or lymphocytes that are predominant. And if that doesn't help you, then you go for immunofluorescence, direct, indirect, then serology, which is basically indirect immunofluorescence, and you can also do salt split skin on that, and you go for ELISA, immunoblot, and other ancillary studies if you want to elucidate the disease further. Now remember this question that I posed to you. So the answer here was bullous pemphigoid. Okay, so but why is the clinical picture more important than histological findings? Look at this. This is a case report of linear arrangement of neutrophils along the basal layer in bullous pemphigoid. So, how did they call this bullous pemphigoid if there were neutrophils? It's the clinical picture that mattered. Because the clinical picture did not resemble any of the subepidermal blistering disorders with neutrophils, they went on to do direct immunofluorescence studies, and with that they confirmed the diagnosis of bullous pemphigoid. And therefore, the clinical picture is more important irrespective of the histological picture, which may be atypical in a number of cases. So bullous pemphigoid with neutrophil predominance is not unknown, though it is usual to have eosinophils. You may have neutrophils, and that doesn't exclude bullous pemphigoid. Your clinical picture is more important. Now, I like this classification by Barnhill. So Barnhill has classified subepidermal blistering disorders into autoimmune, which includes bullous pemphigoid group of disease and variants, and Bullous pemphigoid is really the prototype of subepidermal blistering disorders. The prototype of epidermal blistering disorders being pemphigus vulgaris, and we call them the pemphigus group of disorders. Now, mucous membrane pemphigoid or secretory pemphigoid come under this variant. Dermatitis herpetiformis, linear IgA are the prototype for IgA mediated subepidermal blistering disorders. And then you have EBA and Bullous SLE, which are basically autoimmune blistering disorders which have collagen 7 as a target. Then you have subepidermal blistering disorders due to mutations of proteins of the basal membrane zone, and this includes the EB, the congenital EB variants, junctional and dystrophic, and then you have Kindler syndrome as well. And then you have miscellaneous subepidermal blistering disorders like TEN, toxic epidermal necrolysis, and erythema multiforme comes under that. Porphyria group of disorders, which includes pseudoporphyria, coma blisters, diabetic blisters, and these all are the miscellaneous category. Now you can classify them also based on the cell type. So you have the eosinophil rich variants, which we've discussed already, the Bullous pemphigoid group and its variants. And that's the autoimmune etiology. Then under the non-autoimmune etiology, you have arthropod bites, which we all know produce eosinophils, and then also drug reactions. You can also have this in Wells syndrome. Sometimes in Wells syndrome, you can have eosinophil-rich blisters as well in Bullous-Wells syndrome, which is rare but can happen. In the neutrophil rich variant, basically all other autoimmune blistering disorders are neutrophil rich, and this includes dermatitis herpetiformis, linear IgA, Bullous LE, EBA, and also secretory pemphigoid, which is not really a direct variant of pemphigoid or Bullous pemphigoid. It has multiple antigenic targets, which we'll discuss later, but it is basically an autoimmune disease which is neutrophil rich. In the non-autoimmune category comes Sweet syndrome, Bullous Sweets, pustular vasculitis. When florid, you can also see intraepithelial blisters actually in pustular vasculitis. Erysipelas is another variant where you see lots of edema in the papillary dermis, and then you can have neutrophil-rich bullae as well. And then Bullous urticaria, usually neutrophil-rich, though you may have eosinophils sometimes in this variant. Lymphocyte rich is really rare. Lichen planus pemphigoidus may be considered when the lichen planus component is more prominent, but usually eosinophils predominate in lichen planus pemphigoidus too, which is essentially a variant of Bullous pemphigoid. It's not really a different disease. Non-autoimmune lymphocyte-rich disorders are much more easier to diagnose in H&E, and this includes Bullous lichen planus, fixed drug eruptions, erythema multiforme, polymorphic light eruption, Bullous mycosis fungoides, and Bullous fungal infections. But these are diseases that are apparent on H&E. You don't need any, they don't really trick your brain into thinking that there's something else. Fixed drug eruption is a clinical diagnosis, really. Nobody takes a biopsy for that, but if you do, that's the histology you're looking at. The cell pore variant is interesting. There are only two major cell pore variants in the autoimmune category, which is the Bullous pemphigoid cell pore type and the epidermolysis bullosa equisita. In the non-autoimmune come the EB inherited types, then the porphyria variants, burns, PN, bullae associated with diabetes, and blisters, ovarian scars. Okay, you may have even lichen sclerosis sometimes with bullae, and that comes under blisters, ovarian scars. Bullae, though rare in lichen sclerosis, can happen. Now, so the essential point that I'm trying to make is, apart from some autoimmune blistering disorders, most other diseases, including the non-autoimmune category, can be distinguished by either clinical history and or H&E findings. I want you to go through the list here from the beginning. So Bullous pemphigoid has got a really characteristic history and clinical presentation, tense bullae, usually in elderly patients. Then you have in the non-autoimmune, arthropod bites are easy. Patient gives a history usually, very unusual for patient not to. Drug reactions, again, patient has a clear drug history. Then if you look at the non-autoimmune category, these are all clinically and histologically quite easy to diagnose. They don't really pose a threat. Yes, to some extent there may be overlap, but DH has a clear-cut clinical history. of multiple periodic small papules and vesicles, usually on extensor surfaces, sacral area, etc. Linear IgA usually have small vesicles that are clustered together in sort of string of jewels or pearls appearance. Bullous LE usually has systemic manifestation. Again, histologically, you may be able to see changes suggestive of LE like mucin and perivascular infiltrate deeper down. EBA, again, 50, patients are usually in the 50s, present on their extensor surfaces and pressure areas. Sometimes, rarely, you may have difficulty in distinguishing them, though. Cicatricial pemphigoid is a scarring variant. It doesn't usually, confuse you for bullous pemphigoid because bullous pemphigoid is non-scarring. Lichen planus and lichen planus pemphigoidus are slightly difficult to differentiate, and then you need immunofluorescence studies for that. Fixed eruption, typical clinical EM, typical clinical PLE, the history is a giveaway. Bullous MF, the histology is a giveaway. You usually see the atypical lymphocytes. Bullous fungal infections, yes, clinical history, and if you do a PA stain, it's pretty apparent. Cell-poor variants can be difficult. Yes, bullous pemphigoid and EB can be difficult sometimes, and there you need DIF, I have to admit. Non-autoimmune variants, yes, EB, the congenital type is pretty easy to diagnose clinically. Porphyria and pseudoporphyria, again, you have the sort of eosinophilic deposits around the blood vessels and basement membrane and the capillary bodies. Burns, I mean, the patient would themselves tell you don't take a biopsy for that. TEN, again, pretty easy to diagnose on histology. Bullaceous with diabetes, yes, because they're self-poor bullae, can be difficult. But then if the DIF is the clue here, if the DIF is negative and the patient has a history of diabetes, that's how you make the diagnosis. Blisters, overlying scars, yes, of course, there is a scar. So, to me, the clinical is what matters most. Then I look at the H&E, and in most cases, I do get the diagnosis. But then, sometimes, as I explained earlier, the diagnosis may not be so apparent, and then you need to go for other studies. Now, what are they? Now, I've highlighted bullous pemphigoid, pemphigoid gestationis, and lichen planus pemphigoid because they're essentially bullous pemphigoid in various settings. If you have lichen planus and bullous pemphigoid, you call it lichen planus pemphigoid. If you have bullous pemphigoid in pregnancy, you call it pemphigoid gestationis. They're not different diseases. Okay. However, if you look at this, the same antigen BP180, though BP230 is also targeted in bullous pemphigoid, the same antigen BP180 is also targeted in linear IgA and mucous membrane pemphigoid, and that's important to remember because even though it's the same antigen, they have different clinical manifestations because of the epitope that is targeted. In linear IgA, because it's the IgA type of antibodies and the epitope is different, you have different manifestations. And again, the epitope is different in mucous membrane pemphigoid, and even though it's the same antigen, the epitope is different, therefore you have different manifestations. But then mucous membrane pemphigoid, you can see, can occur due to targeting of either BP180, 230, laminin 332, or alpha 6 beta 4 integrin. The anti-laminin gamma 1 pemphigoid, also called the P200 pemphigoid, usually has IgG antibodies. DH, as I told you earlier, is the other variant with IgA. Mucous membrane can also have IgA, by the way. The IgA variant variants include three diseases, and a DH it has a different antigenic target. As explained earlier, collagen 7 is the target of EVA and bullous ME. All right, but first, before we go into how I would differentiate these various entities histologically, how does one identify a subepidermal blister? And this can be very difficult when you're starting out as a novice, and I had this difficulty, which is the reason why I thought I should explain this. The way one identifies an intraepidermal blister, intraepidermal, not subepidermal, is if you're seeing a layer of basal cells or other epidermal keratinocytes on the floor of the blister. Okay, this is a typical example of pemphigus vulgaris, which you all probably already know. You can see acantholytic cells here, and so basically this is an intraepithelial blister. You know that because the floor of the blister is made up of basal keratinocytes. On the other hand, in this particular lesion, The floor is made up of dermis, papillary dermis. You're not seeing any keratinocytes here. The keratinocytes are all located on the roof. This is a subepidermal blister. You're seeing lots of eosinophils. This is an example of bullous pemphigoid. Now, what about here? What do you think this is? Is this a subepidermal blister or intraepidermal blister? This is a tricky one. You're seeing basal keratinocytes here, and the blister is above it. Can you see that here? And it's neutrophil rich. Okay. Um, this is interesting, isn't it? This is an example of a subepidermal blister, actually, but I'm illustrating this to show you that sometimes in subepidermal blisters, because of the spongiosis, they can become intraepidermal. Okay, so subepidermal blisters sometimes can become intraepidermal, and this is not unusual. The clues being usually intraepidermal blisters, there is acantholysis, which is absent here, and look for a subepidermal split at the edge of the blister. I haven't showed you the section here, but look at the edge of the blister, and you should in most cases see the subepidermal origin. And because of the inflammation spongiosis, sometimes they can become intraepidermal later on. All right, so this is an interesting paper, and I encourage you to read it. The spectrum of histological findings in pemphigoid, avoiding diagnostic pitfalls. And here, the authors have illustrated a typical pitfall. This, on a casual glance, appears to be an intraepidermal blister because you're seeing a layer of basal keratinocytes. However, this is not an intraepidermal blister. This is a subepidermal blister. This is nothing but epidermal regeneration or reepithelialization that appears to be emanating from this eccrine duct. This can occur as early as 48 hours after blister formation, and therefore, when you're taking a biopsy from a lesion, it's best to take a biopsy from a lesion that is less than 48 hours old. Remember that. Now look at this example. The reepithelialization is much more advanced, and here you're also seeing epidermal necrosis. In fact, I have a few cases in archive where, because of the epidermal necrosis, I have called this bullous pemphigoid EM overlap. And how stupid I was, because apparently, according to this paper, and I didn't know this until now, necrosis of the blister roof is a clue to bullous pemphigoid sometimes, but the clue to saying that it is not PEN or EM is the presence of numerous eosinophils within the infiltrate, which favors bullous pemphigoid. Absence of disc keratosis and necrosis in the adjacent non-blistered skin here, and the clinical history, again, as I told you, CPC is paramount, clinical pathological correlation is paramount. This is an example from their study showing complete reepithelialization resembling a pseudo-intraepidermal blister. It looks like pemphigus foliaceus, doesn't it, with the stratum corneum being lifted off. But remember, the way you can identify it from erythema multiforme, if you're thinking about, if you're suspecting this is necrosis, is that there is no disc keratosis or necrosis in the epithelium of the blister floor. Okay, some amount of necrosis should be expected here as well, but this is a reepithelializing blister. So clinical is important here. If you don't know the clinical history, and if somebody says query erythema multiforme, you may have to report that previous case as erythema multiforme. Okay, but if the classical history is of in this patient is that of bullous pemphigoid, you can't call this erythema multiforme or pemphigus foliaceus for that matter. All right. So the prototype of subepidermal blistering disorders is bullous pemphigoid, and these are called the pemphigoid group of diseases. I have explained that earlier. You see lots of eosinophils in this category, and you can see that lots of eosinophils. You can make out the spectacle-shaped nucleus, eosinophilic cytoplasm quite apparent if you've never seen eosinophil before. Often there is some fibrin in the upper papillary dermis at the base of the, at the sort of roof of the blister rather, just underneath the basal layer. That's quite common, and you often see edema, spongiosis within the epidermis, and this is quite characteristic as well, especially in the arterial variant of bullous pemphigoid, or what you call the pre-bullous phase of bullous pemphigoid, before the dermal bulla. But you can also see this adjacent to the bulla in the skin that has been biopsied. You can see often spongiosis with eosinophils, what we call eosinophilic spongiosis. All right. So I told you earlier there are various clinical variants which have been given different names, but they're still bullous pemphigoid. The two confusing entities are gestational pemphigoid and lichen planus pemphigoidus. But then there are other variants, drug-associated bullous pemphigoid, vesicular polymorphic pemphigoid, where the histology and clinical mimic dermatitis herpetiformis. But then when you do the direct immunofluorescence studies, you're seeing IgG and C3, and that's the clue that this is not dermatitis herpetiformis. So, well, can you call this the IgG-C3 variant of dermatitis herpetiformis rather than bullous pemphigoid? Why are we calling this bullous pemphigoid if it resembles dermatitis herpetiformis in all ways? I guess what we call this depends on what the author who first reported called it, and everybody just follows suit thereafter, doesn't it? Anyway, then you have the pemphigoid vegetans variant, which is a flexural variant, rare, but like pemphigus vegetans, produces thicker lesions and acanthosis. Then you have the pre-tibial variant, which is a cell-pore variant of bullous pemphigoid. Now, look at the histological variants. We discussed the clinical variants, but here are the histological variants. Now, this is from the same paper, and they've described sub-epidermal, or that is dermal epidermal blistering in only 54% of their cases. The urticarial eczematous pemphigoid variant was present in 17%. At least focal intraepidermal clefting was present in nearly 15%. Reepithelialization of blister floor was present in about 14%, and blister roof necrosis in about 7%. Okay, some cases showed more than one feature. Of course, there are other variants which I haven't described in their study, but this is a neutrophil rich variant, including the DH-like variant, which I've explained earlier, and the cell-pore variant. So, you have a non-classical histopathology. How does one confirm the diagnosis of bullous pemphigoid? That's the conundrum. As a clinician, I don't bother confirming. If my clinical diagnosis is bullous pemphigoid and I'm not seeing anything untoward in the biopsy that, or I'm seeing histology that has been described in bullous pemphigoid before, like necrosis or neutrophils, I do not bother. I still make the diagnosis of bullous pemphigoid and move on for the sake of the patient, because to me, subjecting the patient to additional studies and asking them to pay money, especially if you're in private practice like me, would not really change the management. Most blistering disorders, as I told you, respond to standard immunosuppressive therapies. So why do I need to rack my brains, unless for academic purposes? Why do I need to rack my brain to sort of elucidate it further if I know clinically it is consistent with bullous pemphigoid? I hope you got it. Okay, so CPC is the most important. But still, if you want to go down further and confirm the diagnosis, you can do direct immunofluorescence studies where you see homogeneous linear deposition of IgG and C3 along the basal membrane if it's a case of bullous pemphigoid. But here is a question. Does homogeneous linear deposition of IgG and C3 along the basal membrane confirm the diagnosis of bullous pemphigoid? That's an interesting question to think about. Look at this here. So in this particular table here, you can see the target antigen and the anatomical localization pattern of immunofluorescence. So we discussed linear IgG and C3, and this can be present not only in cicatricial pemphigoid, apart from bullous pemphigoid, can also be present in bullous LE, EBA, and anti-P200 pemphigoid. Okay, so just because you've got a linear pattern doesn't confirm the diagnosis. But then, if you look at cicatricial pemphigoid, it's clinically obvious. Bullous LE, clinically obvious. And then histology, you may have other clues as well. Then EBA, most often clinically obvious. P200 pemphigoid may or may not be, usually has mucosal involvement, which is not so common in bullous pemphigoid. So that may be a clue. But then, how does calling it by a different name apart from bullous pemphigoid going to change the management is something you need to think about. Anyway. So, yes, well, there is one clue actually which I forgot to mention. If you just have linear C3 and don't have IgG, that favors the diagnosis of bullous pemphigoid. So you can remember that. So, first you do BIF, so you're still in doubt because it's got the linear pattern, but then you've got a whole lot of other diseases that also have a linear pattern. So what do? You can do serology. In fact, I would probably do serology first if you're in doubt, because that's more specific and sensitive than doing direct immunofluorescence. and circulating antibodies to BP1 and BP2 are much more likely to be found if the diagnosis is bullous pemphigoid than the other entities. Right? Still in doubt, what do? Sometimes circulating antibodies can be negative and you still think that this may not be bullous pemphigoid. Okay? Then you can do a salt split skin study if you have the facilities available. It's a modified indirect immunofluorescence technique where you generate an artificial split not in the patient's skin, but use other substrates, and you generate an artificial split between lamina lucida and lamina densa, and the roof basically contains lamina lucida and floor contains lamina densa. And if you look at the antigenic distribution here, you can make out that BP1 and BP2 are present in lamina lucida. So in the bullous pemphigoid group of diseases, including linear IgA and most of the variants of mucous membrane pemphigoid, they stain the roof of the blister because the antigens are in the lamina lucida. However, if you have laminin 332 type of mucous membrane pemphigoid or the collagen 7 targeting EBA or bullous SLE, you have the antibodies targeting the floor of the blister in the salt split skin, and this is how you differentiate between them. So epidermal side, you have these three entities. Dermal side, you have mainly EBA and bullous SLE, but also anti-P200, but also the anti-laminin 332 type of mucous membrane pemphigoid. Now remember, there is a variant of linear IgA which can stain the dermal side. Apparently in that particular variant, it is collagen 7 that is the target, but because collagen 7 is the target, they have now called it IgA variant of EBA rather than the EBA variant of IgA, linear IgA disease. Interesting. What does it matter what you call it? To me, it personally, I don't care what you call it. It's still a sub-epidermal bullous disease. All right, okay. So coming to bullous pemphigoid again, the differential diagnosis in the cell-rich variant, when you have eosinophils, other BP variants, including mucous membrane, except the laminin 332 type, where you often have neutrophils. Pemphigoid gestationis and lichen planus pemphigoidis. If you have neutrophil predominant disease, it's EBA, bullous SLE, DH, linear IgA, the laminin 332 type of mucous membrane pemphigoid. Cell pool variants, these are differential diagnosis. Okay. Now, if you find linear deposition of C3 and IgG in the dermal junction, you can exclude a number of entities because DH is IgA, linear IgA is IgA. PCT, bullous amyloidosis, and bullous diabeticum don't usually present or don't usually have any, don't demonstrate any immunofluorescence. All right. Then, in the indirect immunofluorescence, salt splits can demonstrate immunoreactance in the roof, and then you've excluded, a number of other entities, which is basically EBA, bullous LE, which I told you stain the floor of the blister, okay, and the cell pool variant of EBA as well, okay. So you're left with the cell-rich variant of pemphigoid and its variants. So MMP is the only thing you can't exclude even now, and clinical is easy actually. If you know the clinical, if the patient has got scarring, you can easily make the diagnosis in most cases. How to maximize diagnostic yield in bullous pemphigoid, as I explained earlier. Freshly formed blisters are important, and blister takeoff, the edge of the blister should be visible in sections. DIF should be done, a specimen should be taken from non-bullous perilesion skin within 1 centimeter of the bulla. Avoid taking biopsies of the lower extremity, as these are associated with a higher rate of false negative results in DIF. In elderly patients where widespread pruritic eczematous or urticarial plaques are present, both the clinician and the pathologist should be aware of the possibility of bullous pemphigoid so that you can go for direct immunofluorescence studies if the histology is non-specific and just showing eczematous changes with some eosinophils. So how do you confirm the diagnosis of bullous pemphigoid? You do direct immunofluorescence. Serology is, I told you, the best. Then you do salt split skin, and if it's the epidermal side, you make a diagnosis of bullous pemphigoid. However, you're left, if the salt split skin stains the dermal side, you've excluded bullous pemphigoid, but then you've got these 4 entities to exclude. Okay, so you have to differentiate between these 4 entities, and how do you do that? So you do that by looking at the serration pattern on DIF. So this is not easy, I'm told. I don't look at immunofluorescence personally, but I've spoken to some experts who do look at direct immunofluorescence, and they say it's not easy. Though the books describe looking at the N serration and U serration pattern under direct immunofluorescence, apparently it's time consuming and can be very subjective. Unless you're seeing very thin sections and spending a lot of time, this can be difficult. But then, what do the books say? If it's epidermal blinding on immunofluorescence salt split skin, I told you it's not difficult because there's no other differential diagnosis. It's usually bullous pemphigoid. And if it's IgA, then you've got linear IgA disease, so that's okay. What about if it's dermal binding? I told you that there are four diseases that we need to exclude. That's anti-P200 and the 332 type of mucous membrane pemphigoid. Now, these two have the N serration pattern. So if you look at it, this looks like an N, okay? These look like an U. Can you make this out? So the U serration pattern is seen in collagen 7 targeting diseases, which is the Bullous LE and EBA. And then the linear IgA lambda densa type, which I told you earlier, is now called the IgA variant, IgA type of EBA. So both are basically the same thing. But apparently both have the U serration pattern, which is seen in because the collagen 7 is targeted, and that's how collagen 7 probably is distributed in along the basal membrane. Okay, so but then you're still not able to differentiate between EBA and bullous LE, or between P200 and the laminin 332 type of mucous membrane pemphigoid. And if you want to do that, you now have to go for ELISA and immunoblotting studies. I personally haven't gone this far ever because it doesn't matter what we call them. And if I'm not able to differentiate, bullous LE is the only major disease I want to differentiate, and that I can do serology, ANA, dsDNA studies I can do, and that can sometimes, that can most cases give you a clue along with other systemic symptoms. Okay, so there you go. Best, as I told you, is clinical pathological correlation, CPC. So just a brief overview about the other diseases I've just mentioned. So EBA, the classical mechanobullous type, usually presents with vesicobullous lesions and extensor surfaces, trauma-prone sites associated with scarring, melee, and skin fragility, and this is the giveaway. Though scarring, melee, and skin fragility can be present in other blistering diseases that can cause scarring, including porphyria cutaneous tarda and pseudoporphyria. The histology of these is quite different, and you can differentiate them. The other variant is it's probably mucous membrane pemphigoid, but that doesn't present on the extensor surface and trauma-prone sites. Okay, mucous membrane pemphigoid can also have milia and skin fragility. Then you have the inflammatory BP-like variant of EBA. It can be indistinguishable from bullous pemphigoid and can have an atypical distribution in the face as well. In fact, in a meta-analysis of 23% of patients with EBA, they had mucosal involvement, and that probably is a slight variance, the difference with bullous pemphigoid, because bullous pemphigoid usually doesn't present with mucosal involvement, though I have read recent reports that mucosal involvement can be present in bullous pemphigoid. So, well, if you're in doubt, then this is a scenario where you might want to do direct immunofluorescence and also do salt split skin studies. Okay, so DIF I showed you does not allow to distinguish EBA from other conditions which produce linear immunofluorescence. In ocular EBA, apparently it's IgA, that's the antibody involved. And yeah, so I've mentioned this earlier, I won't dwell into this again. P200 pemphigoid differs from classical bullous pemphigoid in the involvement of oral mucosa, which is much more common, and nail dystrophy, which often we don't see in bullous pemphigoid, and heals with atrophic scars and milia. So clinically and on salt split skin resembles EBA, but with more mucosal involvement. If you're looking at the U serration and N serration pattern, you can differentiate it. There are concomitant malignancies reported with P200 pemphigoid, and these are them. But Japanese have reported psoriasis association, and a few other entities report as associations, though because this being a rare disease, these associations need to be confirmed in larger studies. Mucous membrane pemphigoid is a bit tricky as far as antigens are concerned because a whole load of antigens can be the target. Lesions less than 48 hours duration usually have a neutrophilic predominance. Older lesions, eosinophils increase and later lymphocytes increase. The dermal changes are not very specific, but in late lesions, you may see superficial dermal scarring. And even in early lesions, if the biopsy corresponds to a previous bullous site, you may see scarring. Okay, so yeah, I told you immunofluorescence cannot differentiate mucous membrane from EB. You do need ELISA or immunoblot studies. Okay, serology also doesn't help in a lot of instances. Linear IgA usually has typical clinical lesions, but may not be seen in all cases. Remember, oral involvement is much more common than bullous pemphigoid, and therefore it is a clue, and usually has sub-epidermal blister with neutrophils. Dermatitis herpetiformis, as the name implies, it has a tendency for blisters to appear in clusters resembling herpes simplex, and that's hence the name herpetiformis. Symmetrical distribution and extensor aspects. Oral involvement is underreported but apparently present, and papillodermal microabscesses are usually present in this entity. In contrast to linear IgA, where the entire dermis is involved, papillodermal microabscesses in the first quiz question that I've shown you are much more typical of DH. Remember, acantholysis does not exclude DH. So remember that acantholysis may sometimes be seen. This is an interesting histological algorithm from the Barnhill book again. Now this I like because if lymphocytes predominant, you can look at necrotic keratinocytes, in which case you're looking at the lichenoid group of diseases, including lichen planus pemphigoides, FDA, or erythema multiforme. No necrotic keratinocytes, you're looking at PLE or lichen sclerosus. Again, if there is no inflammation and epidermal necrosis, looking at TEN. If there is inflammation and no necrosis in a subepidermal disease, then you can EBA, I told you earlier, bullous pemphigoid, pseudoporphyrias, etc. Okay, so here they've given two additional clues to epidermal necrosis as a clue to sort of differentiate these entities. This is from the Derm 101, or actually Ackermann's algorithm, diagnosis by algorithm. And as Ackermann has described, the fluorescence is predominantly the basal membrane. Look at whether it's linear, granular. If it's granular and IgA, it's DH. Granular, two or more immunoglobulins, i.e. called the lupus band, it's lupus erythematosus. Linear, if it's only C3, pemphigoid is the diagnosis. If it's predominant IgG with or without C3, then you do a salt split skin and then you can differentiate, as I told you. If it's linear and IgA, then you've got linear IgA dermatosis. So pretty easy once you know the differentiation. And this is a summary of what I've discussed entirely, including the serration pattern and immunoblotting. So it's an excellent algorithm. This particular flowchart from this paper summarizes what I've already discussed in a simple flowchart. So I'm posing the conundrum again. How important is it to solve the conundrum? As a clinician, it isn't very important to me. I often don't do immunofluorescence studies. I've never done a salt split skin study. In most cases, in the clinical picture gives you the answer. But yeah, if there are difficult cases, you might want to go down that route in a sort of occasional rare instances. Thank you very much.